go into some of the Gait stuff while we're there, but we'll come back to that more at the end. And it's harder to see. I actually prefer, and I don't do a lot of Gait analysis in my clinic. We do have a slow speed camera where it'll download onto the computer, and you can slow the stride down and see what's happening at the knee and the foot and all of that kind of stuff. But that's more for our foot and ankle people than it is for me. Okay? So we got her in a seated posture now, and we're talking to her with her legs dangling. What are we looking for? Also patellar position. So what should happen? Yeah, it should track medially, and it should have a flat face facing you. She looks pretty good on the left side, in my opinion. Maybe a little lateral tilt on the right. I don't know what you guys think. But nothing I'm going to say, boy, we need to operate right away. Right? Okay? From this position, because most people sit on the bed first, again, we're not assuming we haven't had any surgical interventions or anything else, we can go ahead and pick up the J sign. So do you remember what that was from this morning? As she extends her knee, it should follow a J upside down J path, right? If not, then we're probably going to have a tight retinaculum. So we're going to assume this is our pathological knee. I want you to just slowly straighten your knee out for me. See it? Now go back down. See it go in? So it goes down and tracks normally. Come back up. And back down. If the J sign is abnormal, you're probably going to have an increased compressive load because she's not clearing out a trochanteric path. You can also see the VMO there as well. So while we're in the seated position, let's see what else we want to do. We did the J sign. We can also do the McConnell's test. We don't have a stool. I got it. I'm good. Simple for demonstration points. So we talked about this a little bit in class. And remember the first thing I said, a lot of people have powerful quads. So you want to be careful just trying to sit here and resist her. You're much better off if you just get your leg in the way. Now I want you to push up against my leg. And does that, what's the sign? Cause pain, right? Then we're going to take her how far? 30 degrees because of the carryover effect, right? And we're going to repeat it again. Now as the lever changes here, I have a much better chance of resisting her. But if I want to, I'm going to get my leg in front of her again. Push up against me. Does that hurt? Nope. Okay. We're going to go to about 30 degrees. Push up. Does that hurt? Full extension. Does that hurt? If it's compressive, it should go away by when? By 30 degrees. Good. Now the other thing you notice, and you should do, particularly if somebody that tells you they have a history of subluxation, stabilize them. So instead of just saying, okay, push against me as hard as you can, not knowing whether she's going to stabilize, use your hypothenar eminence or your thenar eminence and stabilize her and then push. But I don't want to push in, I just want to stabilize. Because the test then is to add medialization. Did that hurt, by the way, when you pushed? Push again, I'm going to let you go a little harder. Push hard, come on, push, 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 push. So, some of you may have a positive sign. Again, the problem with lab settings is we do all this stuff, but unless you see it, it's not as meaningful and not as much residual. So, the McConnell's test then would be for me to become a stabilizer. If you want to use both thumbs, you can actually get better tactile information, but it's hard to hold their leg, especially as you get to higher angles. So I usually would use the heel of my hand, and I will provide a medial force, and she can feel that. And then I'll have her push again. I get my leg in front, of course, and push. And if it relieves the symptoms, then Jenny McConnell says she's a candidate for taping. I say that she's a candidate for further investigation.